Welcome. Today, my name is John Masonis, and today we're going to be having a faculty discussion regarding kinematic alignment in total knee arthroplasty. Our faculty of experts today for kinematic alignment in total knee include Dr. Mark Klaassen from Orthopedic Sports Medicine Center in Indiana, and he is a professor at University of Notre Dame and did his residency at Lutheran Hospital of Indiana. Second member of our faculty today is Peter Thadani. Peter is from Illinois Bone and Joint, and Peter completed his fellowship at the Carl and Job Clinic in California. And then last but not least, Steve Howell. Dr. Howell comes to us from Sacramento, California. Steve is a graduate of Jefferson Medical College residency and is part of UC Davis as an adjunct professor in biomedical engineering. So this will encompass our three experts today from kinematic alignment and total knee. So what I'd like to do today is answer three main questions with regards to kinematic alignment, those being what, why, and how. And in not that exact order, I'd like to start off today with Mark Klaassen, who's going to talk to us about the concept of kinematic alignment and why we should be considering this or why we should be interested in this for primary total knee arthroplasty. So with that, Mark, I'll hand this over to you.
Well, thank you, John. Overall, my feeling about kinematic alignment has been that if we can restore the disease limb alignment, that is going to be best for the patient. I consider myself somewhat of a compartmentalist. In other words, when I get into a patient to look at their knee, I'm looking at where the disease is located. Is it medial? Is it lateral? Is it patellofemoral? And then my first line of defense or first line of approach is, do they need a partial knee? I think the partial knee is a prime kinematic alignment knee because you're basically restoring the joint to its natural ligament tension. And so about 50% of my knees are partial knees. The other 50% are total knees, and in those knees we do need to do kinematic alignment. And I am a firm believer that if we do kinematic alignment, we will make them a lot better. By kinematic alignment, I'm going to try to reestablish the pre-arthritic state. I want to reestablish the patient's, quote, normal, and restore the soft tissue, ligament, envelope, balance, and tension. And that's what we do with partial knees, and partial knees tend to function at a higher level than total knees. And I'd like to see us bring the total knees up to that level, and I think we're getting there more and more, and one of the ways of doing that is through kinematic alignment. I think it'll improve function with an anatomic alignment, and the balance and knee functions should then feel normal. For coronal alignment, traditionally we've looked at varus, neutral, and valgus, and that's how we've always looked at knees. And what we're finding out, there's an article by Hirschman that's really pretty good. It looks at different phenotypes. It looked at 308 non-arthritic knees, and it identified 8 phenotypes, and there were many more than that. It's a rather complex article, but 8 phenotypes cover about 65% of the population. And the current total knee alignment does not consider the natural functional coronal alignment. For example, if you take an HKA, a hip knee ankle angle of 180, and a femur mechanical angle of 90, or a tibial mechanical angle of 90, which is our target, it's only seen in 5% of the population of those that they looked at. So mechanical alignment aims to maximize durability of implants rather than restore the natural alignment. And I think that has traditionally been what we have seen. So I do somewhat of a restricted kinematic alignment. And Steve, I'm sure will comment on this a little later, but if you look at this article, the restricted kinematic alignment, so if you create some boundaries as to what your limits are in terms of what you are willing to accept in a total knee, that is what we call a restricted kinematic alignment. And it represents, this article, when they did that, for example, if they would only allow 3 degrees of maximum varus on a tibia, it represented about 51% of the population. And so the question becomes, do you try to balance between implant survival and anatomy? And I think this is a starting point. What I've done is I have done my knee kinematic alignment, and what this is a PSI guide. I have a lot of experience with PSI guides, and I find that this has really helped me not only to educate myself about kinematic alignment, but also to be comfortable that I'm not getting into a situation which I don't want to do. So it's a kinematic alignment using PSI guides. It allows for pre-planning. It allows me to know what my hip, knee, ankle angle is before surgery and before I ever make my incision. So my knee kinematic alignment allows me to make adjustments in sagittal and rotational positioning as well as the coronal positioning. And I like that ability because I can see what that does to my HKA angle. And it's very, very telling when you make small changes. You can make some significant differences. And I know what my adjustments are that way before I ever get to the OR. So my goal, and the reason I do kinematic alignment, is that I want a naturally aligned knee. I want to maintain the functional soft tissue envelope with minimal injury. And what I've found is that I do not have to do nearly as many releases, if any, when I use kinematic alignment. We're restoring the natural position of the joint. And therefore, your computer, which is your brain, likes that. And alignment is, with my kinematic alignment, I can do both coronal, sagittal, and rotational alignment. And in the end, I feel that as we go down this road, we will meet the patient's expectations much better.
Great. All right. Well, thank you. So as far as the session goes, we're going to have the three speakers complete their presentations. At the conclusion of those presentations, then we'll move on to some question and answer periods. So next up at this point would be addressing the question of how, and this is Dr. Peter Thadani. So Peter, we'd like to have you present your sequence for how you address kinematic alignment in your primary total knee.
All right, so I'm going to go through my learning curve experience with kinematic alignment. I'm relatively new to KA total knees, but I've got some experience, and I'm going to share my thoughts with learning curve and some things that I've observed. And is there a way that I can advance? Oh, here we go. So, everybody has sort of been taught or introduced a traditional way of doing total knees, and the primary goal of a traditional total knee has been to restore a neutral mechanical alignment. And the pioneers of total knee arthroplasty determined that this was achieved with bone cuts that were perpendicular to the mechanical axes of both the femur and the tibia. They felt that, in contrast, cutting the bones in a more anatomic alignment would raise the risk for medial tibial plateau fixation failure, and thus the cuts were made essentially non-anatomically. So, as we all know, the tibial plateau is about 3 degrees of varus with regard to the anatomic axis of long axis of the bone, but the mechanical alignment cut cuts the plateau perpendicular. Similarly, the distal femur cut in a mechanically aligned knee is not parallel to the native distal femoral articular surface. As a result of doing this, the joint lines change, the joint angle is changed, and in order to balance the flexion and extension gaps, the femoral component has to be placed in 3 degrees of external rotation. So we're all familiar, I'll go back, we're all familiar with this kind of a picture and how a mechanically aligned knee is cut. With kinematic alignment, in contrast, it's a much different way of thinking. Kinematic alignment is based on research by Hollister and others that define the 3 axes of the knee and aligns the components in 3 dimensions, interestingly as opposed to aligning in 2 dimensions with mechanical alignment. And the goals are to restore the native distal femoral and proximal tibial articular surfaces, restoring the native knee and limb alignment, and restoring the native collateral ligament tension, so a much more natural or anatomic reconstruction of the knee joint. So first step of learning process, I feel, first you have to accept the K as a complete departure from ingrained traditional principles of mechanical alignment. But you have to trust that it's based on sound scientific research. So when I first started to look at kinematic alignment, you know, like everybody, we're all familiar with the studies that unfortunately state that not everybody who has a total knee are satisfied with the result. You know, we can look to our own practices and see that most of our patients are quite satisfied, but there are some that are not. So I think we're all looking for, you know, a solution or a way or means to improve our outcomes for our patients. So for me, KA was, you know, had an interest in looking at it from that standpoint. Also, you know, when we're taught how to do total joints, everybody likes to say, regardless of whether it's a shoulder, a knee, or a hip, oh, a total joint replacement is a soft tissue operation. So, you know, when you do a total shoulder, you know, you fit the prosthetic parts to fit the soft tissue envelope. When you do total hip replacement, you make the parts fit to the soft tissue envelope. When you do a uni knee, you make the parts fit to the soft tissue envelope. So why with a total knee you cut the bones and then force the soft tissues, the ligaments to fit the bone cuts? So to me, this seems much more natural. You're making your bone cuts to align the natural anatomy and to be in harmony with the natural ligamentous sleeve. So I think that the first step, it's a total retraining of the brain. Again, the typical tenets that we do during surgery with MA knees, femoral mechanical axis, the IM canal, the transepicondylar axis, the AP axis, and on the tibial side you have your mechanical axis, your IM canal, your tibial tubercle. These are all things that you pay attention to during a mechanically aligned knee. In a KA knee, these things are not of interest whatsoever or of any use when performing a KA total knee. So it takes some retraining to just forget about all that stuff. Second step, studying the technique is very important. There's an excellent chapter in Insall and Scott's book written by Dr. Howell that details very well the theory behind kinematically aligned total knees and the steps needed to execute the operation. For me, it took a few times reading that before it really sunk in. Then the next step for me was a cadaver lab, so actually going to the lab and performing one of these procedures in a cadaveric specimen. And then it was very important for me, and I think for anybody trying to learn KA, to spend a day with a reference surgeon. So I went out and spent a day with Dr. Howell, and that really kind of solidifies the procedure and the process. So the third step, then I think at that point you're ready to perform your own cases. I think it's somewhat helpful to know that with Medacta in particular, there's a proctor and a master surgeon program in place whereby you can have somebody come and assist you with your first few cases. You know, Medacta is based on surgeon education, and they firmly believe in educating surgeons, and one of their mottos is the surgeon is never alone. And so even though when you get to the point of performing your own cases, you're always going to have some assistance, whether it be somebody helping you out in the OR or a phone call away. I think for me, I started with straightforward cases with minimal deformity. I didn't want to jump into a case with a big deformity or unusual anatomy that I would potentially get into trouble and not know how to get out of. Then as I became more familiar and more comfortable with the technique, I gradually expanded my indications as I became more comfortable and as I gained better understanding of the principles. The other thing I'll show in a minute, you know, when you start doing these cases, when you look at your post-op X-rays, they look quite different than standard total knee arthroplasties, and so it really kind of maybe scare you a little bit when you first start doing them. And so I think validating with a long axis X-ray and McKay X-ray is important, and also validating with your clinical results. Just seeing these patients post-op and seeing that they're doing very well. So again, departure from conventional thinking in the OR throughout all those other tenets of mechanical axis. With the kinematically aligned knee, it's the femur that really drives the operation. You really have to pay attention and take your time to get the femoral bone cuts correct. See an example here of the bone resections, the distal femoral condylar resections, the posterior femoral condylar resections. Once you've ensured that your femoral cuts have been done properly, and there's a very well-defined set of quality assurance steps that you can perform each step of the way during the operation to ensure that the operation is being executed properly. Once that femur is done, then really everything else follows naturally. The tibial cut is done kind of based on what needs to be done to match the femur and restore and create a happy and balanced ligamentous sleeve. With mechanically aligned knees, we're all taught, it's all kind of burned into our heads that recutting is sort of like a failure. If you have to do a recut of any one of the bones, it's sort of like a failure of technique. It's really not true. In kinematic alignment, the opposite is true. Bone recutting is the correct and only way to achieve balance. So again, throwing out what you've learned from MA and just kind of retraining your brain that, hey, recutting is part of the, sometimes a necessary part of the operation. You have to remember that with osteoarthritis, it's the cartilage and the bones that are abnormal, not the ligaments. So again, why are we forcing the ligaments to match our bone cuts? We should be, doing our bone cuts to match to align with the ligamentous sleeve. And the other important thing to remember, once you start a KA knee, in the middle of the operation, you cannot fall back on MA techniques for balancing. It will not work, and you will end up with chasing your tail and ending up with a knee that's either not balanced, not aligned properly, or both. And so, once you start a kinematically aligned knee procedure, you got to stick with it. And in that vein, it's important to know in the OR before you go in the OR to be very familiar with the steps and the principles needed to execute the operation. We talked about balancing the knee. Again, with MA, we're all familiar with the 9 different types of balancing, too tight, too loose, or just right. With kinematic alignment, there's also an algorithm, but the algorithm, the steps needed to balance the knee are different than with an MA knee. So this chart here, I won't go into it in detail, but this is very important to memorize this before stepping into the OR. And in terms of doing a KA knee, either with instrumented technique or with my knee, I think the my knee is very helpful. My philosophy is I think it's really important to do the KA knee with instrumented technique beforehand. I think it's important because by doing it that way, you really gain an understanding of exactly what you're doing during the operation. You're doing the quality assurance measures. You don't have the ability to just kind of get lazy or shut your brain off with my knee blocks. You have to make your bone cuts right. You have to check that they're right, and instrumented technique really forces you to think about what you're doing as you're doing it. I mentioned before postoperative validation and reassurance. So, this is a postoperative X-ray of a kinematically aligned knee that I did, and one of my colleagues might look at this knee and say, "Oh boy, Pete had a bad day. He couldn't, he wasn't seeing straight. He didn't get those cuts right, and that knee looks a little bit wonky." So initially, your X-rays are going to, they're going to look a little bit off. It's going to look markedly different than your mechanically aligned total knee X-rays. But I think for me, what was helpful is then going to a doing the McKay X-ray. So this is that same patient. This is the McKay X-ray, and whereas we thought with the short AP X-ray on the previous slide, here's a full-length leg alignment X-ray. And in this one, I can see that I've restored the native joint line angle, the native joint line height. The joint line is perpendicular to the floor, and I've restored his his natural mechanical axis to the contralateral opposite side. So this is validation for me that I've made a nice anatomic reconstruction of this patient's knee. So this was a real eye-opening and validation, I called it my validation case. So early on in my KA experience, I thought I'd been restricting to, knees with relatively little deformity or more straightforward cases. And I thought, if I'm really going to make the leap and adopt this technique, I'm going to see if we can put our money where our mouth is and apply this to all patients, all comers. So here's a woman, 75-year-old woman with end-stage valgus osteoarthritis, collapsed lateral compartment. You can see a markedly valgus mechanical alignment. And so I look at this case, and from an MA perspective, I think, oh boy, okay, I'm going to have to The lateral femoral condyle is hypoplastic. I'm going to need to overly externally rotate my femoral component. I might have bone loss on the lateral side. Boy, what's my MCL going to do? So I've got all these, things swimming in my head for an MA technique. But I went ahead and I did a kinematically aligned knee, and I was able to execute the operation, and we were able to fit her soft tissue envelope. I made the proper cuts, and I was able to restore her native pre-arthritic alignment. Her MCL was intact. I didn't need any augments. I didn't have to worry about externally malrotating the femoral component. And here I've restored her native joint line height, her native joint line angle, and her native mechanical alignment of that leg with a KA reconstruction. So, in summary, I think kinematic alignment represents a significant divergence from traditional principles. You have to retrain your brain that it's a totally different operation. The learning curve involves completely rethinking your operative steps. There are intraoperative quality assurance measures that have been established and validated to confirm that every step of the way during the procedure that you're doing it right and that you're going to wind up with a good reconstruction. For me, the radiographic results as well as the patient outcomes validate that we're doing these operations properly and encourage me to continue on. And as with anything, the more cases you do, the more it makes sense, the easier it becomes. And I'll tell you what, the more kinematically aligned total knees I do, in the cases when I fall back and do MA knees, it just seems very foreign and very unnatural to be cutting these bones in those kinds of ways. So, thank you.
So Dr. Howell is going to present to us sort of exactly what he thinks kinematic alignment is and also some outcomes data.
Okay, I was asked to talk about this combination of a medial ball and socket implant with lateral, that's laterally unconstrained, and its combination with calipered kinematically aligned TKA as sort of a promising combination for restoring high-level activities to patients, as well as satisfying the older patient with a high-level clinical outcome with restoration of function and motion and a more normal-feeling knee. I do have disclosures. I am a consultant and receive royalties from Medacta, and I receive royalties and a consultant from Zimmer Biomed Sports Medicine. I want to briefly talk about the definition of kinematic alignment, share with you that the native knee has a medial ball and socket that centers the rotation of the tibia on the femur in the medial compartment, and a lateral compartment that lacks constraint throughout the flexion arc. I then want to share that the low-constrained conventional TKA medial lateral insert for most of the inserts that I've used in my career provides stability that's comparable to an ACL-deficient knee with partial meniscectomies. And I believe that's why some of these patients have exercise intolerance. They want to walk 2 miles and they get effusions. They want to go to the gym and they get pain in the soft tissues. So I believe that having a more constrained medial socket and lateral unconstrained plateau may increase the exercise tolerance for these patients that want to remain active. I think Freeman was prophetic. A medium ball and socket and lateral unconstrained cruciate retaining or cruciate substituting, that is posterior cruciate substituting insert, combined with kinematic alignment is a promising strategy. So let's look at a definition of kinematic alignment. In our view, kinematic alignment co-aligns the axes and joint lines of the femoral and tibial components with the 3 kinematic axes and joint lines of the pre-arthritic or native knee without a ligament release and without placing limits on the degree of preoperative deformity that you treat and the degree of postoperative correction that you achieve. So these are some poses of a femoral bone model looking from the medial, lateral, coronal, and axial projection. The green line is the axis about which the tibia flexes and extends, and as you can see, it goes through the center of the circumference of the medial and lateral femoral condyles. Anterior and proximal to that is another transverse axis, the magenta line, and that's the axis about which the patella flexes and extends, and that's parallel to the first joint line. Parallel to the first axis and parallel to the joint lines. And then there's a longitudinal axis, and that goes through the center of the medial compartment, and therefore the medial compartment functions as a ball and socket during flexion, extension, rotation, and this does so when there's compression across the knee joint. If the tibia is distracted, then the rotation is through the center of the knee. But during activities, when we're interested in the behavior of the total knee arthroplasty, the kinematic axes function in this orientation either parallel or perpendicular to the native joint line. Hence, it makes perfect sense to the patient, at least, that if you just resurface the joint by placing the implants coincident to the native joint surfaces, then by definition, the axes of the components are co-aligned with the axes of the native knee, and that restores the natural resting lengths of the ligaments so they don't have to be released, they don't get too tight, they don't get too loose, and this restores stability and flexibility to the knee and gives the patient a more normal feeling knee. Now, Peter covered these 3 landmark studies on knee kinematics, so if you don't have a lot of time to read, I would suggest that you just read these 3 papers, and this will provide the scientific basis for kinematic alignment. The first one was by Ann Hollister, actually a hand surgeon, published in Core in '93, and she discovered the flexion extension axis in the femur, about which the tibia flexes and extends, and prophetically said that knee motion, that knowing this location and activity of this axis, can determine the knee motion in prosthetic design and reconstructive surgery, and it has profound implications, which it does, because when you change the implant so that it's outside the bound of the native surface, something's tight, a ligament has to be released. If it's recessed or countersunk, something's loose, and instability, very difficult to treat. These 2 undesirable consequences are markedly diminished when you restore the native joint surface with the implant. Coughlin and Bainen's group from Vermont discovered the second transverse axis, the flexion extension axis in the femur, about which the patella flexes and extends, and also determined that it was parallel to the joint line and parallel to the other flexion extension axis. And once again, the Freeman paper, which we'll revisit in a moment, that described the movement of the normal tibial-femoral joint, was initially published in the Journal of Biomechanics, and therefore may not be commonly read by the orthopedic surgeon. But this paper outlined the importance of the IE axis and the medial ball and socket joint. So let's look at the native knee and look at this medial ball and socket that centers the rotation and a lateral compartment that lacks constraint. So any MRI, here's an MRI of the medial side of a normal knee. Actually, it's ACL deficient. You can see the bone bruise in the posterior medial tibia. There's the menisci providing the socket. There's the ball. There's the center of the ball. And then here's the coronal projection of the medial compartment. You can see the meniscus, once again, a socket. And there's the same size ball, and there's the center of the ball. Now, if we go to Freeman's paper, they elegantly showed back in 2004 that from 0 to 120 degrees, the medial femoral condyle hardly moves from full extension to full flexion. So here's the same pose medially. We've drawn a bisector of the medial compartment of the medial tibia. We best fit our ball or our circle with the center, and in full extension you can see it's centered on the bisection of the medial compartment. In deep flexion, it's the same position. But look what happens on the lateral side. This makes it a ball and socket medial. On the lateral side, the lateral femoral condyle is here in full extension, but then when we fully flex, you can see that the lateral ball and socket is now way posterior to the bisection line, indicating that there's very little constraint on the lateral side. And if you look, you can see that the lateral meniscus is fallen off posterior, which means that the lateral insert should be flat. It should not have a posterior lip. The posterior lip is consistent with conventional inserts of most of the ones that I've used in my entire career. But why is there stability provided on the lateral side when it's not needed, and taken away and made less constraint on the medial side? Hence the importance of this ball and socket concept. So let's look at it visually. The medial meniscus is held firmly to the medial tibia in the native knee by the coronary ligament. This forms the medial socket. And if we watch this knee move with compression across it, you can see that the rotation occurs more or less around a medial pivot point. Now, if we look at the lateral side from the lateral projection, the mobile lateral meniscus is not constrained to the tibia with a coronary ligament like the medial side, and hence when you flex the knee, the lateral meniscus actually falls off the back. and therefore the lateral plateau, as shown by Pinskarova, is a flat surface. So this is the scientific basis and kinematic basis for a flat lateral tibial surface. The low-constrained conventional TKA medial lateral insert that, as I mentioned, I've used for years, provides stability that's comparable to an ACL-deficient knee with partial meniscectomies, meaning it allows the medial tibia to translate anteriorly and posteriorly where the medial ball and socket does not. So let's look at some examples of these inserts. I've put in 2,000 Masonis CR knees, medial lateral constraint, symmetric more or less with a posterior lateral lip. The triathlon, I put in about 1,300 of these with kinematic alignment, the same. The Attune, I've just done a few of these. And Vanguard, I did about 900 of these. But these inserts are all the same. There's constraint and a posterior lateral lip, and there's flattening of the medial side to not create a ball and socket. Hence, you're using both sides of the insert to stabilize the knee, when the native knee mainly uses the medial side. So let's look at a typical conventional insert during kinematic activities. This is actually a kinematically aligned TKA, and this is of a base plate that has the low constraint, and you'll see it behaves like an ACL deficient knee. Here's the patient bending, and although it's very hard to see with the fluoro, we can go ahead and look at the 3D positions in a moment. But before we do, I want to share with you that this patient was randomly selected. The Oxford score is 45, the Womack score is 11, the Forgotten Joint score is 69, and the Knee Society score is 130, and her activity level is UCLA of 6. This is, by all rights, a very good knee. This is what it looks like when you do a 3D model to 2D image registration. There's the AP pose. We're going to now show the lateral tibia, medial tibia, and axial view of the tibial component. And now you can see that the lateral side that tends to roll off the back and catch the posterior rim because the entire tibia is translating anteriorly, as you'll see here. And this can lead to a little posterior edge wear. I think that by and large, it's clinically not that much of a problem. You do see posterior wear insert in some knees, but in KA knees, it's relatively rare, as it is in the mechanically aligned knee. But I think this AP to and fro movement stretches the soft tissues and gives this sort of exercise intolerance to our patients. And we know that this was not caused by malrotation because we have post-op CT scans showing that the orientation of the tibial component and femoral component is correct, but you also see a little uncovering of the posterior lateral tibia, which increases the risk of this posterior lateral edge load. Now let's move to what I think is an advancement in thought is Freeman's prophetic concept of the ball and socket and lateral unconstrained CR and CR insert. So this is a model of the medial compartment of a left knee, and you can see how the knee flexes and extends and rotates on the medial side in the socket. Hence, the medial insert ball and socket combination replaces the ACL function, reduces the risk the tibia translates anterior during kneeling, squatting, and other activities. If we look at it, you can see that there's a cutout for the posterior cruciate retaining to allow you to retain the posterior cruciate, which I believe is invaluable in a total knee replacement and increases the risk that the patient is going to like their knee and think it's normally functioning. This is a posterior substituting one without the cutout posteriorly, but you'll see that both of them have sort of a ball and socket configuration on the medial side. And if we look at the lateral side, you can see that the insert is flat and that the insert extends all the way to the back end of the metal. So there's a low risk of posterior wear and insert. This is a case where I did an anatomic, I used the anatomic ball and socket sphere tibial base plate, which is shaped to match the tibial resection surface. And I want to show that it covers all the way back to the posterior lateral tibia, reducing the risk of posterior lateral edge wear. So there's a sphere cruciate retaining on the right and a sphere cruciate substituting on the left. Same patient. This is the CT scan of both knees showing the orientation of the femoral component. There is the translation of the orientation of the femoral component to the tibial component, showing negligible malrotation of the tibial component on the tibia. And these tibial components were best fit to the tibial resection. And you can see there's the superimposition of the tibial implant on the pose of the implant on the CT scan, and that there is a proper setting of the flexion extension plane parallel to the knee, the insert covers the back end, and there's no posterior lateral rim to wear, and there's a low risk of posterior lateral edge loading. So the medial socket, if we look at this again, on the it pivots medially, and the lateral side allows great motion, and hence there's more natural internal and external rotation with flexion extension of the knee, which does not cause the soft tissues to be bound up, reducing the sensation of stiffness as the patient does activities. We know that this medial socket works even in mechanically aligned total knee arthroplasty based on a study by Marcus Pandy in the University of Melbourne. He measured and compared tibial femoral joint motion for one cycle of ground walking in patients with either a medial ball and socket, a posterior stabilized or cruciate retaining mechanically aligned knee. So there's the medial ball and socket, the implant we've been talking about, the sphere, and then there was a posterior stabilized conventional with the sort of low constraint medial lateral insert and cruciate retaining. And if we look at this slide that shows on the x-axis the medial position to the left, -50 to +50 on the right, which is lateral, and AP on the y-axis, you can see that the medial socket during overground walking stays and pivots centrally on the medial side, where actually the pivot point with the low constrained inserts, which is the conventional inserts that we all currently use for the most part, that the pivot point goes to the lateral side because there's not enough constraint medially. So to summarize, we've covered these talking points. We've shared the definition of kinematic alignment, which is to co-align the three axes of the components with that of the native knee, and we do so by doing what? Simply resurface the knee. If the implant is proud or outside the bound of the native joint surface, you have a tight ligament, you have a stiff knee unless you do a release, which increases the risk of instability. If at some knee position the implant is countersunk, you have a loose knee, you have instability, you have to add plastic or change a bone cut, and that then can make the knee too tight in another position of the knee, and this creates these unsatisfactory patients that have dissatisfaction. Go back and just do a little brief research. Read those 3 papers, scrub the video here back to that slide, get the references, and read those 3 seminal papers that discuss the native knee that has a ball and socket, that it rotates around the medial compartment, and that the lateral side should lack constraint. Understand that if you're currently using one of the more commonly available inserts that has less constraint medial and lateral, you're really reconstructing an ACL deficient knee with partial meniscectomies. And this is why some of your patients have exercise intolerance. They want to walk the mile or 2 miles and they get effusions. They're okay at a half mile or a mile, and you tell the patient to be happy. Perhaps a better approach is to satisfy our patients. It will increase your practice. It will make you more successful and make you and your patients happier. Freeman was indeed prophetic. I believe that the medial ball and socket and lateral unconstrained insert and implant design coupled with calipered kinematic alignment is a promising strategy for restoring the levels of activity. And I thank you very much from Sacramento, California, and Lodi Memorial Hospital. If you have a chance to visit me, I'd be happy to host you for a day or 2 or 3 days of total knee replacement using the kinematic alignment technique. Thank you.
I really wanted to touch base with each of the faculty to ask them a simple question, which is, what made you consider and convert to kinematic alignment? So why don't we start in that order? So Mark, I know you gave us some of your answer, but if you could just repeat for us now, what is it that drove you to kinematic alignment?
So in the end, I want to score an A+ on every patient. And in order to do that, I think I need to put them in their natural alignment. I think that is going to be the best. And if I can put in a knee without doing the releases and put them back to where their computer is used to it, I think they will do the best. We've managed to do that with a hip, but in a knee we've always gone to this kind of unnatural mechanical axis. I mean, so we have a knee that's arthritic, you take and resurface it, you put them in a mechanical axis of 0 that they've never been in, and you make it unstable by taking out the cruciate ligaments. Well, why are we surprised that people have difficulty? So my uni experience has certainly driven me more and more towards kinematic alignment, because I think in a uni we're putting people back in their ligament balanced state. And so it makes sense to me, and as I go down this road, I'm getting more and more confident in kinematic alignment.
How about you, Peter?
Sure. You know, I think like every other surgeon, I mean, you know, we should always be trying to do better for our patients, and certainly, you know, the majority of our patients are happy with the results, but not everybody, and there are those outliers that are quite unhappy, and so, you know, we're always looking for the next thing to solve that problem of the unhappy total knee patient, and so that's what sparked my initial interest in kinematic alignment. And then as I started to study about the theory and the principle behind it, it really made a lot of sense that, you know, you're really restoring the knee back to a pre-arthritic natural state. You're shaping the bones to fit within the soft tissue envelope, and you're really restoring the native kinematics, the native anatomy, as you are with any other total joint replacement procedure. And I think the example of a uni knee is a great example. You're really just you know, putting back what you're resecting and restoring the bones to how they ought to be and how they were before the knee became arthritic. And you know, the arthritic process, it's a cartilage and bone wear process. It's not a ligament damage type of process typically.
So Steve, take us back. What brought you to think about research and really invest yourself into kinematic alignment?
As you may or may not know, my main interest for years was ACL research. So, you know, we spent a lot of time learning about the complications of ACL when the graft's in the wrong position. If it's too anterior in the tibia, you lose extension. If it's too vertical, it pinges on the PCL, you lose flexion. And when it's in either of those two positions, sometimes the ligament stretches. So you have an increased risk of instability and stiffness when the implant's not in the right spot, meaning the ACL graft. So after we sort of exhausted ourselves in 2006, we were approached by two engineers about doing PSI, so we developed the Otis knee at that time. And it made perfect sense to not do mechanical alignment based on work by Hollister and Eckhoff and Coughlin. I mean, in the first place, the mechanical axis isn't an axis, it's a line. Nothing moves around. There's no functional relationship to that line that goes from the center of the hip to the center of the knee, center of the ankle. It's a dogmatic alignment. When you look at how the knee truly moves, it's unrelated to that. It's just based on the joint surfaces. That's where the rotational axes are located. So we knew this, and I said to myself, well, why does the knee get stiff? Total knee gets stiff. Why is it unstable? The only explanation is the parts are in crooked. Crooked from how the knee wants them, because the shape of the knee prosthesis is pretty much the same as the knee. So we just used that sort of simple philosophy, and as both Mark and Peter have talked, we started off with the easy stuff, simple varus, no valgus, then expanded. Now what you find is there's really not a knee that you can't do with kinematic alignment. In fact, the more severe deformities, the easier they're to do, much like the nice case Peter showed with that valgus deformity. A lot of people would have ended up with a constrained implant, releasing lateral components, over-straightening the knee, making the lateral side tight. So over the last 13 years, and somehow 5,500 of these that I've done, we have found that the complications and the problems with mechanical alignment are by and large solved by kinematic alignment. Implant survivorship, better with KA. Risk of varus tibial loosening, negligible with K, much less than mechanical alignment. Soft tissue releases, which cause all kinds of hostilities and problems for the surgeon, negligible with kinematic alignment. Better functional outcome, better motion, higher exercise tolerance, less visits to the office with the complaining patient. You love going to your office. You can turn the patient around that had the first knee to have the second knee done within 3 months, 4 months, 5 months, probably 50% of the time. And it's just a wonderful way to practice medicine. Total knee replacement now is the most reliable orthopedic surgery procedure that I've ever done with using this technique. I can pretty much, I hate to use the word guarantee, but you lower the risks of all these other problems. Patella tracking problems are lowered. Why? Because people that have constitutional varus that you put to neutral, you increase their Q angle. And that's why you see a lot of patella tracking problems with MA, which are markedly reduced with K, as long as you don't overflex the femoral component.
Great. No, I appreciate that explanation. And so just summarizing from all three of you, it sounds like every one of you inherently in this discussion we're unsatisfied with, or noticed your patients who are unsatisfied with your traditional mechanical alignment techniques. So it looks like you all ventured out. It's Steve, obviously you doing it on one of the earlier adopters and pioneers of this. So you brought up the comments about patient's anatomy. So to each of you, do you have limits on the varus valgus bone resection? So are there guardrails on this kinematic alignment? So let's start with you again, Mark, I guess. Are there limits on your varus valgus bone resection angles?
Well, I guess I still do have some limits. I will go, I mean, standard limits have been 3 degrees of varus, but I'll go more than that if I'm actually planning it. But I use a fairly long stem, and so I have to be careful with that. So sometimes I'll have to shorten the stem because you're putting it in a way that the prosthesis wasn't really made to be placed. So if you're using a longer stem or filling up that canal, you have to be a little bit careful. I think this particular prosthesis, ball and socket with the flat lateral side of the tibia, is really helpful with this kinematic alignment.
So could you give us and give some of the viewers, surgeons, some guidelines? So where would you draw that line? You're initially starting out in kinematic alignment. Where would you recommend that they go back to mechanical? What degree of deformity of a varus knee? Let's pick that. So the varus knee, Steve. I agree in your case, like you say, you're tapping the ball.
Well, I'm just going to say, for example, when I started this back in 2006, we did PSI guides, and I can only get one guide made a week because of manufacturing issues, and I would do 4 total knees a week. And how would I pick it? I'd say, well, this is a mild deformity, so I'm going to try KA on this one. But I'm doing KA. I'm not going to limit anything. I'm just going to do it and see what happens. The other 3, I'll do MA. And as that went on, you realize that the patients that were getting better with a quicker recovery, with better, less effusions, happy off the walker, driving the car, less obligations with their family, having to take care of them, were the KA patients. And then you just started to say, okay, maybe 3 months ago I wouldn't have done this knee, but I'm going to try it KA this time, like Peter did with that valgus knee. And the next thing you say, okay, I'm going to expand my indications, but I don't blend. There's no blending here. Either you decide you're going to do KA and you do it, or decide that this is a knee you're a little nervous about doing KA, then don't do it. Don't call it restricted KA. Do MA, and if you do try to blend it, don't call it restricted KA, call it expanded mechanical alignment, because it does not adhere to the kinematic principles of restoring the native joint surfaces. That's what you do. So when you change the alignment from the native joint surfaces, you no longer are co-aligning the axes, you're requiring ligament releases sometimes, and that is not kinematic alignment according to the foundation of our studies and papers and the data that we've presented.
Perfect, thank you. So Peter, tell us, so in your experience embarking into kinematic alignment, where have you set those limits for yourself in your practice?
Well, initially, I was limiting my KA cases to patients that had very minimal deformity, if at all. And then, as I showed that example with the lady with the valgus deformity, I decided, hey, let me try this and let me see if the technique works. And lo and behold, it worked for her. I didn't have to do any ligament releases, and I was able to balance her quite well and restore a native or natural mechanical alignment. So, basing on that experience, the next time I went back and did a valgus knee, I was confident that I'd be able to do the reconstruction, but also knowing that, hey, if I get into trouble, if that patient really didn't have an MCL, I can do a semi-constrained implant. I can use a short stem. With modern implants, we can use cones to really enhance our component fixation. So for something like that, for a natural deformity, I've sort of expanded and sort of released or expanded my limits or guardrails, so to speak, such that I don't really have so many limitations anymore on the deformity. Now, I am, I guess, still a little bit hesitant, and maybe Steve can comment on the patient who has end-stage osteoarthritis, but they've got a pretty significant extra-articular deformity, so a previous malunited femur or tibia fracture, something like that, such that the limb is in really, a fair bit of malalignment as compared to the contralateral limb. And with that type of patient, I'm maybe a little bit concerned that if I do a KA knee, I'm still going to leave that limb in a fair bit of malalignment. So that's maybe one sort of difficult case where I have yet to resolve how KA fits in.
Great. No, I think that's a good point. Those cases do show up occasionally. So obviously, extra-articular deformities a little farther away from the joint. If they're mild deformities, you can handle them. If you're doing mechanical access, you might make that adjustment at the joint line. But obviously, sticking with a true kinematic alignment, I'm assuming, Steve, most of these you would, if the deformity was significant, you would address that at the site of the deformity as a separate event? Okay.
No, I ignore the deformity. I mean, you think about it. So I learned this back in 2008. I had a guy with a crocodile bite in his mid-femur, went on to an infected malunion, required a skin flap. There's nothing you could do about his deformed limb. It happened at age 18. He presents to me at the age of 57 or something. Works as a game warden. He got bit by a crocodile as a trainee in the game warden in South Africa. So I look at this horrible knee. What am I going to do? I can't realign his femur because it had an infection, with a vascular pedicle graft. So I said, I'm just going to do kinematic alignment. So I told him, I said, your leg's been crooked your whole life, hasn't it? Yep. I said, well, here's what I'm going to do. It's a little more varus because you've worn, or a little more bowed because you're worn on the medial side. I'm going to straighten that out. But you're going to have the same limb alignment that you've had for 40 years. What do you think about that? That's fine. So I did him. It's been 12 years. Got an Oxford knee score 44. He can walk 10 miles a day on his knee. They don't go on to fail. Failures are caused by instability, caused by mechanical alignment. And so that leads to this knee that doesn't feel right. So the surgeon thinks, oh, the leg's straight. We can tell Mary you got a straight leg. She doesn't like it. So we've done a variety of high tibial osteotomies. There's a perfect example. You go and try to correct that at the joint line when 1.5 centimeters distal, there's an 8-degree, varus or valgus, how you want to call it, osteotomy or limb malunion, and try to do it at the joint line, and you start releasing stuff and everything else, and it's a hodgepodge of nothing. So just tell the patient, we're going to make you less deformed than what you are now, but you're still going to be a little crooked. Would you like to have that, or would you and have a better feeling knee, or would you like me to straighten your leg for you, which I can do, but you might not like your knee? Which would you prefer? Don't worry about the implant longevity. This is all blown out of proportion. I mean, we did a follow-up study, everyone in 2007. We checked, got a hold of them in 2017. Survivorship, 97.5% had the same implant without an exchange, but 20% of the patients were dead. So the question the patient is really asking you is not how long my implant's going to last. They should ask you, how long am I going to live? So all of this, we're going to have better survivorship for the 1%, but you've got 25% of people that are miserable with their knee and won't come back and get their second knee done, and are telling their friends, this was the worst experience I ever had. I mean, those are the ones that we ought to be treating, not the 1% to improve the survivorship. And by the way, when you do KA, you get better survivorship, because our 10-year study was of the Vanguard knee with a 97.5% survivorship, and Adolph and Keith just presented their results 10-year. Their survivorship was about 95 or 93%, and their manipulation rate was 5%. You don't want to manipulate the knee? Do KA. It's negligible. And when you do have to do it, it's usually just for deep flexion. Someone comes in with 105, 110 degrees, they're stiff, they complain of stiffness, just give them a little push, and you can do that manipulation at a year, 2 years, or 3 years out, and they get their motion back, and they'll keep it as long as the components are placed with kinematic alignment. All the rules and foundations that we've had with mechanical alignment no longer apply with KA. So that's what I think Peter did a nice job emphasizing, that it's a mindset difference. You've got to be willing to open your mind, but start easy, do the easy ones, but you're going to find some of these multiple level deformities where they're, femoral shaft or down at the tibia at the ankle, and you're going to say, how am I going to correct this? And you're going to be forced to say, I'm just going to fix the joint. And when you do, you'll find that your results will be good, and you won't have to worry about the survivorship, because the knee is balanced there where it's not balanced when you do all the releases with the MA. That's why the MA failure rate is generally higher, and that's why you get varus tibial loosening. Mark, I want to make one last point, because Mark said he uses long stems sometimes with the tibia. I've not used a long stem on a primary knee since 2006. I cut the tibia and varus, whatever it is, it's anatomic for me or native, but the the mechanical arm guys, so you cut it in varus. I have used cruciate retaining implants, so symmetric base plates for that whole group. I had to medialize, I undersize, and negligible varus tibial loosening. So the cause is due to the instability generated by MA, and the lengthening of the stem may give you a little happiness or at least feeling of security. But if you want to get rid of that, just do KA throughout the whole knee, forget the long stem, and you don't have to worry about it.
So that's a great segue into my next question. So I'm currently actually attending a meeting, and we reviewed, Steve, we reviewed your outcomes data and your 97.5% survivorship data this morning that was presented by Dr. Guo Li. But in addition to that, we've talked about, and each of you today have discussed some different implants that you've used. So from a generic standpoint on the cruciate retaining versus posterior sacrificing with a cam post versus a medial congruent implant, I'd like each one of you to talk about your preferences in the kinematically aligned knee, which one of those implants, and do you think PCL retention or PCL sacrifice is more desirable? So let's start with you, Mark.
So I have always maintained the cruciate ligament, the posterior cruciate ligament. I'm a strong believer in maintaining that. I think it gives you proprioception, it gives you more stability, it gives the patient more balance. And what I have found is with kinematic alignment, I find that I do not need to do any kind of releases. With mechanical alignment, I have to do some releases sometimes because it's tight, but I still maintain the PCL. I do not do any kind of substitution of the PCL. I really prefer not to do a PS knee, and I like the new CR insert that is present with the one that Steve was showing, and it works really well, and I'm able to keep my PCL. I think the PCL is important. In the long run, I would tell you that part of the reason why bicruciate ligaments retaining knees have struggled is because they need to be in kinematic alignment. If we had a bicruciate retaining knee and we put it in the kinematic alignment, those people will do phenomenal.
I agree. Steve just about fell off the couch there. But so it's a great point, and I think an interesting portion of what you brought up, and that is you use a patient-specific instrumentation from the MyKnee side on the Medacta sphere. So I agree 100% with you. I just finished giving a talk on bicruciate knees this morning of why the outcomes are probably not so good. We need to match the patient's anatomic slope, and we need to match their anatomic varus valgus angles if we want the cruciates to behave as they're supposed to. So I think it is obviously a bit ludicrous to cut the tibia at a completely different slope and a different varus valgus angle and expect these cruciate ligaments to maintain their normal tension throughout our flexion arc. Particularly, we're using implants that may not be, that were never designed for kinematic or anatomic relationships to start with. So that's a great point. So I'll go on to you, Peter. PSCR, is the cruciate PCL retained or substituted for? What's been your experience?
Yeah, I've always been a PS surgeon. That's the one sort of thing that I was taught, the tradition that I've not given up. I've always sacrificed the PCL. The PCL is an intra-articular ligament, as is the ACL, and I think I worry that may not function normally regardless of how you reconstruct the total knee. I think late PCL rupture, late PCL instability is not an insignificant thing. I've revised some knees that were initially done with cruciate retaining, and they've developed late PCL instability, had to revise them to PS knees. I'm comfortable with the sphere implant with the medial ball and socket articulation. It's very conforming, and I think that sacrificing the PCL in that situation, that I'm still going to have good posterior stability.
I saved the best for last on this question, I'm sure. But so for you, you've used many different implants: cam post, posterior substituting, cruciate retaining, cruciate sacrificing with the sphere or medial congruent. So tell us now what you've learned or what you think is the optimal design.
I think CR, here's the issue. When you cut the posterior cruciate, you get variable laxity of the flexion gap. You know, everybody's a little different. So you might get a 2 millimeter jump, symmetric medial lateral at 90 degrees if you cut the PCL. Somewhat tolerable. You can reduce the slope a little bit, or sometimes you'll add a little extra insert, but then you'll lose a little extension. You make the compromise. And, you know, I use the CS Medacta insert from August of 2017 until October of 2018, so 14 months, probably 240 or 50 knees, and now I've been using this CR, which has been always my preference. I think Peter's right that the ball and socket helps you if you were to, you know, your PCL, let's say you retained it and it did rupture, or perhaps you cut it a little bit with the saw on the posterior cut. You say, I think it's good enough. The ball and socket might, I think, can help you with that. But what I found is that your flexion gap becomes unpredictable. And you'll have some people where the flexion gap will jump 3 or 4 millimeters and more lateral than medial. And I just think if you're, you know, when you're doing 75-year-old ladies and gentlemen that are just going to church and going to bingo and going to the store, you know, you put a PS in them, it's fine. But the Australian registry, our own experience in our clinical practice, we've got these 50-year-olds that had their ACL reconstructed at 25 years of age and 20 years of age that have these worn-out knees that want to remain fit. And these people with a PS implant have exercise intolerance. Flexion gap sloppy, or then you have to do what's called a gap balancing technique, trying to, you know, restore stability and flexion by getting a symmetric laxity at 0, 30, 60, 90, which there could be nothing further from being unphysiologic. Nice paper, review paper in JBJS this past issue showing that the natural flexion gap after 15 degrees, after 0, the medial side opens more than lateral compared to extension, and the lateral side always medial than medial, so it's trapezoidal. Extension gap tight, rectangular in everybody, flexion gap trapezoidal but variable. And we all know that with arthroscopy. You scope you do 3 medial meniscectomies, one's easy, one's not so hard, one's really hard. Why? Because the hard one has very little medial laxity. Then you do the lateral meniscectomy. Lateral hemijoint always opens more than the medial joint. When you tighten the lateral side down and you make it a rectangular flexion gap, you end up with a tight flexion space. The patient can, I think, has a very hard time feeling that's a normal knee. So you into all these compromises when you start cutting the PCL, and you can't set the balance of the knee like we have. We used orthosensor. We've got 4 papers published, 1 in Core, and the Core conclusion, we were asked to put this in, that there's no need for the orthosensor and calipered kinematic alignment because we restore the native forces and the sensor doesn't help us make that decision. And our forces were 3 to 4 times lower on the medial side and 5 to 6 times lower than the lateral side without release than after mechanical alignment with release. So my point of view is mechanical alignment, they say they balance the knee. It's, how should we say, illusory. It's illusory. You're not balancing anything. If you define balance as the forces in the medial lateral compartment that match the native knee at 0, 30, 60, and 90 full flexion. KA does it. The only way MA can do it is if MA actually does kinematic alignment by mistake. And that's really why the MA patient does well, is because they're doing KA within some boundaries in a fair percentage of the knees because the joint lines aren't distorted too much. So when an MA guy says, I get good results with MA, I said, yep, you are, because you're actually pretty close to kinematic alignment. But when you take some of these more varus and valgus knees and put them to 0, you get a lot of hardship in those patients, and it makes your office hours miserable, absolutely miserable. So reduce that risk. Anytime you cut a ligament, the risk of instability goes up. Learn to save the PCL, but if you want to start not saving it, fine, do KA that way. But I think as you move through the process and learn and grow, you'll find that that ligament, the biggest one in the knee, is an important friend of yours. And as Mark said, the only reason you recess the PCL with mechanical alignment is because your implants are outside the bound of the native surface. That's all that it is. Your slope's wrong, your posterior offset's wrong, your rotation's wrong posteriorly. Those things are negligible with caliper technique, so you don't release the PCL. In fact, whenever you release a ligament, your implants are outside the bound of the native surface, and it's just kinematically malaligned.
Since the 3 of you started your kinematic alignment, has it changed at all the way you manage the patella in your total knees? do you find yourself resurfacing all the patellas or none, or selectively resurfacing? So let's go down the line. Mark, you first.
So I resurface. I have found that using an anatomic patella seems to do quite well, and I have not really seen any patellar problems because I think we're restoring a natural alignment. And I just have not seen that. I think that you'll see more of that with MA alignment.
Yes, I agree with Mark that the anatomic button is better. We have a paper that's published on our patellofemoral complications. By and large, the etiology was flexion of the component beyond 5 or 6 degrees from the anatomic. And so that reduces the size of the trochlea, because you usually have to drop the size of the implant when you flex, and it also delays the engagement of the patella. We had a bigger problem when we resurfaced, and we had a bigger problem with the anatomic with the dome button. And then I did a thing. Robert Barrett came out as a good friend of mine. I think he's a believer in the concept of KA. He's visited me 3 times, most recently about 2 months ago. And, you know, I gave a trial of 500 knees without resurfacing, and unfortunately, I thought the kinematics were great. It would be optimal to not resurface. But I'm going to tell you that 10% of those I went back and put buttons in. And those people did better after the button, by and large, probably 85% of them. And I ended up with 2 deep infections, which I very rarely get with a primary knee. It's been less so that I've now had quill or the braided lock suture, so I think it's a little more watertight. But you go back in on a knee that you did a year ago, the soft tissues don't close as nice, they don't hurt as much. And when you just put the button in, they move quickly, and I think they tend to leak a little bit. So I always tell them I might have to, you know, put a brace on them. But I think the anatomic button is probably a good idea. And I do agree with Mark. I mean, we don't change the Q angle. We restore the native limb alignment, the native Q angle, and the native position of the femoral component, which then optimizes the trochlear position. So there are, we have studies. Charles Riviere out of Imperial College in London. We asked the research question: does a kinematically aligned prosthetic trochlea or a mechanically aligned prosthetic trochlea better restore the native trochlea? And the answer is the kinematically aligned one. And that's because the Q angle change is so big when you do mechanical alignment from the native alignment.
I always resurface the patella. You know, I know the studies that show that there's no clinical superiority of resurfacing versus not resurfacing. I think resurfacing, you know, is sort of hedging your bet and making sure that there will be no late patellar arthritis as a cause of failure of a total knee. I really like the anatomically shaped, the offset domed patella. I guess I'm a little concerned that, you know, the implants that we use are designed for MA knees, whereas we're putting them in with the KA technique. But I think with the, you know, the implant that I use, and I think most of them, even if you're doing it, putting it in with the KA technique, the patellofemoral articulation still works. And I think partly because, or primarily because, you know, you're restoring the native anatomy and native kinematics to that knee. So I've not had any issues with resurfacing the patella.
Great.
With the kinematics.
And so that brings us to Steve. You made a concept or a comment about restoring to the native alignment. So I'll give you a little bit of the podium here. You have some experience and some recent manuscript preparation for the windswept knee deformities. So what do we do, or what do you find when you don't have a normal knee to compare to?
Well, we don't use the normal knee anyway. I mean, when we do calipered kinematic alignment, for example, if someone is bow-legged, and I'm using the Medacta spear implant, which is 9 millimeters thick distally and 8 millimeters posterior, as soon as I look at the leg without the x-ray, I've already planned the operation. I already know my cuts. My distal medial cut that I measure with the caliper will be 6, my distal lateral will be 8, my 2 posterior cuts are 7. And that, by definition, restores a native alignment. It is that simple. So then, when I cut the tibia, how do I judge that I have the native alignment restored? Is when the knee is in full extension with the spacer block, and I have negligible varus valgus laxity with the knee in full extension. So if I put a spacer block in such that one side is snug, let's just say for argument's sake the medial side, and I go varus valgus and the lateral side's opening 2 millimeters, that means I'm loose lateral relative to medial, which is tight. So if I want to eliminate that varus valgus toggle, I'm going to have to take about 1.5 millimeters, 2 millimeters of bone away from the medial tibia, so I simply do a varus recut. And I judge that I've been successful at my balancing, if you will, when I put the spacer block in and I have no VV laxity. And that restores the native alignment. We know that because we took 100 and some patients that had no other skeletal abnormality other than their knee replacement, and both limbs otherwise were normal, and we restored the side-to-side distal lateral femoral angle within 3 degrees the other side 95% of the time. And we did the same with the proximal tibial angle, which, according to Eckhoff, is the normal side-to-side difference in most people. So we really don't need the other side to do it. So you asked about the Winset. I can't wait to see how the JBJS people reject this paper, but we're going to send it in. We had 19 of them, and we did KA on both sides, and we asked the research question. What's the distal lateral femoral angle? Are they different after the surgery? Nope. They're pretty much 89% within 3 degrees of each side, which is normal side-to-side difference. Proximal tibial angle, the same, within 89% within 3. What's the outcomes? The same. What's the number of ligament releases? None. What's the type of implant? Primary. So the KA simplifies, and the windswept deformity, when the patient looks at their legs, it's the same on both sides. So what it tells you is that the pre-arthritic or native alignment does not predict whether the osteoarthritic deformity happens in a varus or valgus manner. It's unrelated to that. And you know that for a fact because you have people with a valgus limb that will come in with wear medial. You'll see some of our Asian population with a valgus knee when they have a varus orientation. And you see plenty of people with severe varus native alignment that never go on to get osteoarthrosis. So once again, these preconceived assumptions or dogmatic assumptions about what causes what that we've had with mechanical alignment really don't apply. So Peter, unfortunately, there's more things that we need to sort of re-examine as being factual. And so KA is the perfect solution to the windswept because you do the same principles on both legs, no releases, primary implants, and go home. Very simple. I think I sent you the paper, John. I think I sent you the manuscript. We're almost done with it. We've got a little tune up. So if you want, you can read it. Didn't I send it to you guys yesterday?
I read it this morning.
Yeah.
Yes.
Yeah, it was amazing, you know, and I had a visiting surgeon come. He said, "What about the windswept?" I said, "I don't know." I said, "But we got a huge database. Let's go back 4 or 5 years when I've been doing caliper kinematic alignment, find all of them, and then find those that had bilateral caliper KA, and let's see what they have." Yeah, it was very much an eye opener.
Excellent.
So we did a paper. We had 19 patients with this so-called osteoarthritic windswept deformity. This patient is a typical example, worn lateral on the right knee, worn medial on the left knee. So then we did caliper kinematic alignment, and you can see that the distal lateral femoral angle of both legs are within 3 degrees, and the proximal tibial angle within 3 degrees, and the limb alignment is within a degree. And this is sort of what we found. So if we look, this is a plot, and let me explain it to you. You're going to see 3 for alignment. This is, on the x-axis, is the mean of the distal lateral femoral angle for both knees of the same patient. So if one distal lateral femoral angle was, let's say, 8, and the other one was 6 on the same patient, then the average would be 7. And then over here is the difference, those 2 angles for that patient, which would be 2. So that patient would be 7, and whoops, let me go back, and then the x would be up here at the 2 position. So ideally, if we had perfect symmetry in our bodies, which Eckhoff shows that we don't, there's normally a 3-degree variability from right to this point. You can see that the majority of these have a difference that's less than 3 degrees with the exception of these 2. So we do restore a symmetric alignment in these patients within the variation of the normal population. Here's the proximal medial tibial angle, the same plot. Most everything is within the 3-degree range. The outliers are these 2. I'm going to go to the outcome. So here's forgotten joint score. So let's just say that we say to the patient, you have 2 knees, your forgotten joint score, what are they? So you say, okay, they give you a 70 in one knee, a 75 in one knee, and a 65 in the other. Then that would be an average of 70, and the difference would be 10. So that patient would be up in here. So what you see is most of these patients have a very small difference in the forgotten joint score between the varus and valgus knee, and the mean difference is 0. That's this solid line, 0. So essentially they think both knees are the same for their forgotten joint score. You can see that the tendency is the scores are fairly high. The mean value I don't have here for each knee, but the overall values are quite high, and the Oxford knee score, once again, very high. So patients that tend to have a low average Oxford knee score in both knees tend to have very little difference, meaning they tend to rate both knees poorly. So the point to take away from the windswept deformity is they just happen to be a varus deformity in one knee, a valgus in the other, just like you have a patient with a valgus knee and maybe a normal knee on the other side, or a varus knee and a normal knee on the other side. They're really just two independent knees, and you just treat them as independent events. And when you do with kinematic alignment, you restore, as we showed in the first slide, pretty much the same distal femoral angle and proximal medial tibial angle, and the same hip knee ankle angle in both, and you get the same clinical outcome.